My name is Iman Abdjabbar. I am an R3 emergency medicine resident from King Faisal. How was the day? It was long, huh? At the end, everyone's leaving? Okay, let's wait for them. So my presentation is gonna be about asthma exacerbation, okay? Yeah, okay. So everyone know about asthma, right? Any thoughts about asthma? Common presentation, common in our culture, children, young people, older people, all come with asthma, especially these days. Now it's summer and all the dust and everything. This is the commonest presentation, it's one of the commonest presentation you will see in the AR, okay? So what's the asthma? Any thoughts? Chronic inflammatory? Okay. Yeah, all pathophysiology, right? You have studied this at the beginning of the year of the medical school. So it's chronic inflammation. All the mediated cells is gonna be attacking the lung, okay, and cause some change in. Okay, the good thing about the asthma, this change is reversible. That's what we know. But over the time, it's become irreversible. Okay, so what we have is airway inflammation. It's all caused by the mast cell, eosinophils, all these cells, bronchial hyperresponsiveness, okay, and reversible airflow obstruction. It's always, you have to know it's reversible. This is the magic word, okay? So how do they present usually? We don't care now for pathophysiology, you have studied it in the beginning. How do they present to the AR? Asthma. Shortness of breath, what else? Cough, what else? Wheezing, okay. This side. Increase, or it's the same shortness of breath. What else? So let's take this patient. We have a 32-year-old female presented to the ER with acute dyspnea, dry cough and wheeze, typical asthma patient. She gave a history of recurrent attacks in the past, typical presentation. She admit she have increasing symptoms with exercise and dust exposure. Okay? Not all the time you have a specific triggers for the attacks, okay? Is it always this simple? Patient mild asthma, you give her some oxygen, oh, I have improved, I'm gonna go home now. It's not that easy. Sometimes they will come like this. She cannot breathe at all, she cannot talk, she cannot express anything, okay? Even her statin is dropping, you don't know what you do. Is this a simple asthma? Maybe it's other things, okay? Dyspnea has come with a multiple diseases, it's not only asthma. So this is casual, it's dense, a lot of words. It's only like it's dividing how to differentiate between the asthma attacks. We have the mild, moderate, severe, and for the red flag is respiratory arrest, okay? All these is the symptoms the patient present with. Like, let's see in the beginning, where is it? Yeah, here for the mild patient, the one who, the commonest visitor to the ER, they will come walking to the ER, they will tell you I have my attacks now, I try my inhaler at home, no improvement, okay? They will talk normally. Sometimes they may be agitated, okay? Increased respiratory rate, they can't do everything. Sometimes the vitals is normal even, okay? Then we come to the moderate. The moderate one, okay, they will have, even at rest, they will have shortness of breath. They will take in phrases. They will not talk in a long sentence. She will say one word, stop, take a breath, one word, stop, take another breath, and like this. And always, always, from moderate to and gone, they will always be agitated, okay? It's the same, we have the vitals here, increase the pulse, okay? She's in a stress situation now, she cannot breathe. And even the severe one, okay? Here, at the end, this is for the diagnosis, okay? Functional assessment. You will assess the function of the lung of this patient. Anyone know what is BEF? BEF? Beaked expiratory flow. And what about the other one? FEV1. Okay, you know that. So in ER, what we use is spirometry to assess the forced expiratory volume in the first second, okay, to see the status of this patient. Above 70, this is normal. 70%, that's mean percent from what you predict from this patient or what is her usual forced expiratory volume. Okay, 70% and above, that's a good thing. And then we have for the moderate, you have 40 to 69%. And then in the severe, you have less than 40%. These patients are scary. Okay? And then at the end, the end column, we have the respiratory arrest. Okay? These symptoms should make you worry if you see it in any patient, asthmatic patient. Let's see. So what's my red flags? I have a simple asthma, but this one looks different. So anyone know what is paradoxical respiration? Patients come with these symptoms. Paradoxical respiration? No one? So paradoxical respiration, it's what? The patient is gonna inhale the air, but what happened is he's gonna deflate his chest and inhale through his abdomen. So you'll see his abdomen moving outward and his chest inward through inhalation, which this is considered abnormal respiration, right? And then when he expirates, his abdomen is gonna go inside and his chest is gonna go outside. This indicates that he's in respiratory distress. He may go into respiratory failure. The other one, alteration of the mental status. Any confused, agitated patient, okay, what do we have else? Exhaustion, lethargy, okay? These also indicate that patient is going to respiratory arrest. He cannot continue breathing in this rate because over time, the asthmatic patient, the respiratory rate is gonna increase. It's gonna reach 30, 40, you may say even 50, okay? The other thing is silent chest. Anyone know what's silent chest? Silent chest. Mm-hmm. No breathing, why? Why there's no breathing? Because what's gonna happen is asthma is he is gonna trap all the air inside his chest. Okay? So it's called air trapping. The air is inside his chest. He cannot take more breathe, all because of airway obstruction. Okay, all these symptoms, it's also indicating that he's going to respiratory failure. Pulsus paradoxicus. Anyone know what's pulsus paradoxicus? It's written there. Change in blood pressure during inspiration. Why? What happened during inspiration? Because of increase in intrathoracic pressure. When you have increase in intrathoracic pressure, okay, that pressure is going to affect the blood flow that's coming back to the heart. That's why you will have blood pressure drop, okay? All these, if you see it in any patient, that's mean this is impending respiratory failure. You have to pay attention to this patient. It's not simple asthma, just put him in oxygen and give him the medication and that's it, okay? But at the same time, not every asthmatic patient is only an asthma. What else? What's my differential diagnosis at the beginning? You will not gonna label the patient the moment he comes through the ER and say, oh, this is asthma, this is MI. No, we don't do it like this. You have to run through differential diagnosis, okay, exclude everyone, okay, and at the same time, you treat what you think is the appropriate diagnosis, okay? So what's the differential diagnosis for asthma? Pneumonia, okay, what else? Pneumothorax, COPD, all come with the same presentation. This side, what? Bronchiolitis, okay. Heart failure, yes. Allergic reaction, good one, okay. Allergic reaction, they always forget that one because allergic reaction is gonna come with respiratory symptoms. Okay, what else? They mentioned pneumothorax, the girls. Foreign body inhalation, airway obstruction. Okay, good one. So let's see, these are one of the tops that give you the same presentation as asthma. Acute heart failure, which is called cardiac asthma. The patient, when he have a heart failure, what's gonna happen? He's gonna have pulmonary edema as an effect because of dysfunction of his cardiac muscle. And at the same time, he will have wheeze, and you may mistake it as an asthma attack. Okay, upper airway obstruction, we have mentioned it. Multiple pulmonary emboli. Emboli is gonna give you also, BE is gonna give you shortness of breath at the same time. Aspiration, foreign body, gastric acid, tumors, interstitial lung disease. So any lung pathology is going to give you the same effect. But through your history, through your physical examination, you have to rule these out. And sometimes if you suspect something, you have to investigate it, okay? So management. I have this patient, the female, the first one. She came to you, and she told me, I have always recurrent. And this time I had it again, okay? And I used my inhaler at home, but there's no improvement. So what's my point of care? What do I want to do for her? She already had used her inhaler at home, right? So mainly what I want to do is reversible of the airway obstruction. That's her presentation, right? By repetitive or continuous administration of inhaled beta-2 agonist, ensure adequate oxygenation and relieving of this inflammation. So the first three that we saw at the beginning, which define the asthma, I want to reverse all that, okay, through my management. But first, what happened? Sorry. I'm stuck. Can I have help, please? Small break to collect your thoughts. Okay. So we had that patient, as we mentioned. She came through to your AR. What's the first thing to do? ABC. Thank you so much. What else? Vitals, right? I want to know her status. What is the from my that table? Is she mild, moderate, severe? What else? Correction for what? Inflammation. Okay. I see. From the beginning. Okay. You want to decide that immediately, the moment you saw the patient. Okay. What else? Examination, taking history, right? What do you mean by correcting inflammation? You have mentioned it twice, right? Okay. So you want to start treatment, medication. I'll give oxygen. That's what I want to hear. So any patient who come with a dyspnea, or any patient coming complaining of chest pain or shortness of breath or anything, or he cannot speak, he didn't complain even, but you see him, he's breathing so fast, okay? First thing you want to do is ask the nurse, please, put him in a monitor, give him oxygen, and see his vitals, okay? Sometimes at least let him take a rest, okay? Take his breath, and then remove the oxygen and measure his saturation in room air. I always need the saturation room air to decide the severity of his attack, okay? But you don't leave the patient without any oxygen. Whenever you see a patient in distress, put him in oxygen, please, okay? So we put him in oxygen, we assess the patient, we do the ABC, and we saw his severity in the table, and we decide we want to go through with the treatment. So what is my choices for treatment? Inhalation, okay. Steroids. What's inhalation? Inhalation is only one word. What's the medication? Ventolin, okay. What else? Systemic steroids. Okay. So let's start. So my first choice is gonna be beta-adrenergic, okay? It's what we use in the AR is short-acting beta agonist. You give it to the patient through nebulization. Anyone know the doses? For pediatric, for adults? Usually you go with 5 milligram for the adult and 2.5 for the pediatric. You always give repetitive dose, as we mentioned at the beginning. You don't give only one, okay? And you always, the first thing, you have to keep it in mind. You have to examine the patient before the medication and then reassess the patient after medication to see how is he going with the treatment. Because after that, you will decide based on your reassessment, is this patient gonna go home, or is he gonna be staying in a hospital for a long time, only under observation, or is he gonna go for the ICU, right? Then we have the corticosteroid. It's also part of the treatment. We always use it. We can use it as we usually give it as an IV or PO. There's no difference if you use either routes, okay? Inhalation one is usually used for the long term, but for acute attacks, you always go for the PO or the IV. But nowadays, even the inhaler is going is used as a modality for treatment, even acute exacerbation. Anticholinergic medication, and you know what is that? The one medication we always use. Ebratropium. Ebratropium. So the anticholinergic medication usually acts in the large airway. At the same time, the beta agonist is work at the short airway. That's why when you combine both medication together, they give you maximum effect. Okay? So if my patient, I give him this treatment, okay, let's see, I give him 3 doses back to back. That's what the order we give to the nurses. Please give the patient Ventolin, let's say he is an adult, 5 milligram plus Epratropium, 500 microgram through nebulization, and I want to reassess him again after giving him the medication. He have taken his course, you reassess, there's no improvement. What is the other modality? You give the corticosteroid also as a part of the treatment. There's no improvement. What do? You give again another three doses back to back. Thank you so much. Okay, there's also another modality you use it because there is a range after reassessment and you see there's no improvement. We have mentioned at the beginning, okay, that if if it's more than 70%, that's a good thing, and you're gonna discharge the patient. He's in a mild attack, and he improved after the inhalation. But if he's less than 40%, at that time, you're gonna consider another modality. The patient is getting worse. He's now using more accessory muscles than before. And that's why when you consider the other modality, you will see it used in the AR. You will go for magnesium. We give it as an IV, 2 gram, and then we have the epinephrine. Epinephrine usually used with the allergic and the anaphylaxis shock. They give it also as a helper in the asthmatic patient. Then you will go more advanced. There's no improvement still. You will go for non-invasive post-pressure ventilation. And we know what's that? CBAB and BiBAB. Have you heard about it? So it's give a breath under pressure. It's non-invasive because it's only mask. You put it in the face, okay, and it's gonna deliver air under pressure. It's gonna open the alveoli, okay, and at least improve the movement of the mucus, which is obstructing the airway, and that's what's gonna improve the symptoms. Then we have a ketamine. Ketamine is sedative medication, but also at the same time they have noticed it have a good effect an asthmatic patient. Is going to enhance it's going to relieve the obstruction and the spasm of the bronchi. Okay? And at the end, you give everything, and the patient's still in distress. His respiratory rate is increasing. He becomes silent chest now. His level of consciousness is deteriorating. Glaucoma score is decreasing. At the end, you will go for mechanical ventilation and you intubate the patient. Intubation for asthmatic patient is not an easy. Patients sometimes may die even from asthma attack. Okay? Sorry. So what's the risk factor for death? These risks, you have to look for them in the history to decide, okay, this is a patient is risky. I don't want to play it safe with him. I want to give him the whole medication, everything. This is the factor you always have to look for it in the history at the beginning when you talk from the patient or anyone with the patient. So you'll have previous severe exacerbation, any history for intubation or ICU admission. It's considered something severe. Okay, 2 or more hospitalization for asthma in the past year, 3 or more ED visits for the asthma in the past year. So if he has been hospitalized twice or more, or he had visited the AR 3 or more, and then we have hospitalization or ED visit in the last month, then use of more than 2 MDI short-acting beta-agonist containers per month, current use or recent withdrawal from systemic corticosteroid. You always have to pay attention to these and ask about them in the history. Okay? Sorry. So the last slide is gonna be like an extra info. Anyone know how to use MDI? So how do we use it? The MDI. This is the commonest question you're gonna be asked in the AR. The patient is gonna come to you, especially the first time you prescribe MDI for a patient. Okay, he's gonna come to you. He's gonna go to the pharmacy, collect his medication, and come back, and ask you, doctor, please, I don't know how to use this one. So how are you gonna explain to him how to use it? Shake it. Okay. Okay. Anyone know the steps? So first of all, let's do it like this. First step, you're gonna tell him, please, okay, remove the cap from the MDI, right? Then there is a spacer. You know what is the spacer? Okay, you're gonna attach the spacer. Okay, you're gonna shake it. Then place it. No, there's a step before place it in your face. Always, always, everyone forgot this one. You have to tell the patient you need to exhale. Okay? Exhale deeply. Okay? And then put it in your mouth. Okay? When he is going to inhale, he's gonna press in the MDI and inhale slowly for 10 seconds. You have to calculate, it's gonna be 10 seconds. After that, he will remove it and exhale slowly. If he's gonna use it for another puff, he's gonna wait for 1 minute, shake it again, and do the same process. Okay? You have to memorize it because you are gonna be asked a lot about how to use MDI. Okay? For what? Ah, okay. Yes? I have to wash his mouth. Yes. Thank you for the external. Okay? Any question? Thank you, everyone.